Hi there, my highly valued, treasured, and esteemed viewers and listeners. Welcome back to your channel of choice. My name is Dr. Nath Arma. I am a clinical pharmacist by training and by profession, and I am the founder of Progressive Pharmacotherapy Consultants, a premier virtual clinical pharmacy institute for capacity building for healthcare workers. The Virtual Clinical Pharmacy Institute with a difference, where patient safety, medication therapy management, and optimal clinical outcomes are very, very crucial and non-negotiable to us. Here, we seek to remain your premier source of crucial tips for very high impact pharmacotherapy services. So I humbly urge you all to sit back and spare me part of your very precious time to share with you some very useful tips which may prove very, very handy in your line of duty. So I welcome you all to part 124 of our pharmacotherapy MCQ series majoring in infectious diseases. Welcome. And the first question reads, Mrs. WMM, a 47-year-old female patient, presents to your comprehensive care clinic for follow-up. She has a past medical history of HIV diagnosed 60 days ago. She also suffers from hypertension, which is controlled, and asthma, which is controlled as well. Currently, she takes elvitegravir, co-formulated with cobicistat, tenofovir alafenamide, and emtricitabine. And she has been taking this regimen for the past 42 days. She had a repeat lab testing 14 days ago, and she reports good adherence and tolerates her regimen well. Her viral load is suppressed, and her CD4 count is steadily increasing. She has good immunologic response to treatment to the highly active antiretroviral therapy. Unlike at baseline, her chemistry values reflect normal CBCs and LFTs. Her serum creatinine has increased from 1 to 1.8 milligrams per deciliter. So my question to you is, which of the following regimen modifications would you recommend to the clinical team managing Mrs. WMM's case? Would you recommend they continue HART regimen because renal changes are not likely to be attributed to these drug therapies? Or would you recommend they continue the current ARV regimen because renal function has not actually worsened? Or would you recommend they change to a non-tenofovir containing HART regimen because renal function has worsened? Or would you recommend they change elvitegravir co-formulated with cobicistat to a boosted protease inhibitor regimen because renal function has worsened? I'll give you 10 seconds to choose the correct answer. So I would propose they continue the current HART regimen because renal function hasn't actually worsened in this particular case. Now, the time interval of serum creatinine changes coincides with those of cobicistat, that is within 2 to 4 weeks of initiation. Now, the changes from baseline of less than 0.2 milligrams per deciliter represent inhibition by cobicistat of tubular secretion of serum creatinine with no changes in eGFR. And that makes answer A incorrect. Therefore, the renal function has not worsened on the current treatment. And in my opinion, B is the correct answer. Answer A is incorrect. Now, because the changes in serum creatinine did not continue to worsen, and tenofovir alafenamide has not been associated with renal tubular or renal tubulopathy, switching to a non-tenofovir-based regimen is not necessary at this moment, and that makes answer C incorrect as well. Let's move to the next question, please. And the next question reads, Mr. DJJ, a 26-year-old male patient, is admitted to a general medical ward. A new diagnosis of disseminated mark infection is made. He is non-adherent, and 24 months ago, his first regimen was changed to TAF and FTC, tenofovir alafenamide, and emtricitabine, with boosted darunavir basing on resistance testing. Today he informs the HIV consultant managing his case that he has defaulted for over 12 months. A bad patient indeed. Today, the HIV consultant initiates mark therapy using clarithromycin 500 mg orally twice daily, together with ethambutol at a dose of 1,200 mg orally once a day, and rifabutin at a dose of 150 mg orally once a day. So my question to you is, how should the HIV consultant further manage Mr. DJJ's case, since he proves to be non-adherent? Should the physician restart the highly active antiretroviral therapy in 2 weeks, but change rifabutin to 3 times a week dosing? Or should the physician restart the highly active antiretroviral therapy in 2 weeks, but change tenofovir alafenamide to tenofovir disoproxil fumarate? Or should he restart his most recent HART regimen in 14 days' time? Or should he restart the patient's most recent HART regimen today? I'll give you 10 seconds to choose the correct answer. So the HIV specialist should restart the highly active antiretroviral therapy for this particular patient in 2 weeks, but change tenofovir alafenamide to tenofovir disoproxil fumarate. Now, to minimize the risks of iris, highly active antiretroviral therapy initiation should be delayed for 2 weeks after treatment for MAC infection. That makes answer D incorrect. I would like to add that rifabutin induces P-glycoprotein, which may reduce the absorption of TAF. There is that interaction that would be of significance. Do not administer the two together. It is recommended not to co-administer rifabutin with tenofovir alafenamide to prevent treatment failure. And that makes answer C incorrect. I'd just like to add that this interaction does not exist with tenofovir disoproxil fumarate, TDF. So that makes answer B the correct choice. I would just like to emphasize that rifabutin dosing with strong 3A4 inhibitors such as darunavir and ritonavir necessitate reduced rifabutin dosing to 150 milligrams. Now, I would like to emphasize that more recent data in HIV-treated patients with TB showed lower rifabutin concentrations when dosed 3 times weekly, suggesting inadequate dosage. So do not go there. Do not switch to thrice weekly rifabutin, and that makes answer A incorrect. Then I would also like to add that it is now recommended to dose protease inhibitors with rifabutin daily and to monitor for rifabutin adverse effects, which may include, for example, neutropenia, if I remember well, and even uveitis. Let's move to the next question, please. And it reads, KTF, a laboratory technician at your hospital, accidentally pricks herself with a needle which she used to obtain a male patient's blood sample. And the source patient, who is admitted to your general medical ward, has pneumonia and anemia, and some of his symptoms include fever, a cough for 3 weeks, weight loss, and a marked lymphadenopathy. He has a past medical history of hypertension, end-stage renal disease, and syphilis. So my question to you is, which of the strategies listed below would be the most appropriate regarding Mrs. KTF's post-exposure prophylaxis? Would you test the source patient for HIV RNA, then start PEP if it happens that the patient is positive? Or would you perform a rapid HIV test on the source patient, then start PEP if the patient is positive? Or would it be true that the source patient may not have HIV, so PrEP is not indicated? Or is it true that you should start post-exposure prophylaxis for 28 days without further testing? I'll give you 10 seconds to choose the correct answer. D is the correct answer. I would advocate for initiating PEP for 28 days without many further tests. Remember, these patient's symptoms are highly suggestive of HIV infection with an OI. Remember, they've mentioned fever, weight loss, lymphadenopathy, and anemia. And there are also risk factors for HIV infection, such as syphilis. So that makes answer A incorrect. Now, I would like to remind you that an opportunistic infection diagnosis in a patient with undiagnosed HIV would indicate advanced infection and typically high viremia. And that's another risk for HIV transmission to such a laboratory technician who accidentally pricks herself. As a result, PEP prophylaxis is indicated in such a scenario, and that makes answer D correct. I'd just like to underscore the fact that post-exposure prophylaxis should not be delayed in a healthcare worker awaiting the results of an HIV test, and that makes answer B incorrect. I'd like to remind you that rapid HIV testing will yield a result more quickly than an HIV RNA testing, which can take several days to even a week to report. Therefore, answer A is incorrect in my opinion. Let's move to the next question, please. And it reads, Mr. LNK, a 36-year-old gay male patient, presents to the clinic for results review after being tested for HIV prior to initiation of PrEP. He is asymptomatic after a bout of flu accompanied by gastrointestinal upset 7 days ago. He routinely tests his HIV status, and he obtained negative test results 90 days ago. He has one male HIV positive sexual partner who isn't on highly active antiretrovirals. They frequently have unprotected sexual intercourse, and 7 days ago, Mr. LNK's primary care doctor tested him, and his results were as follows. So the HIV antibody antigen test is positive. The HIV-1/HIV-2 differentiation assay is negative. So my question to you is, which of the following is the most appropriate assessment of Mr. L and K's HIV status? Is it true that he could have chronic HIV infection but should receive an HIV Western blot test to confirm this diagnosis? Or is it true that he has chronic HIV infection and should be initiated on highly active antiretroviral therapy as soon as possible? Or is it C, he doesn't have HIV infection and should receive PrEP and risk reduction counseling and be tested for HIV in 90 days' time? Or is it D, he could have acute HIV infection and should receive an HIV viral load test to confirm the diagnosis? I'll give you 10 seconds to choose the correct answer. So he could have acute HIV infection and should receive an HIV viral load test to confirm the diagnosis. Now, when initiating PrEP, clinicians should assess the risk of HIV infection and eligibility according to the CDC guidelines. Now, this particular patient is at a substantial risk since he is an MSM and he uses condoms very inconsistently. His eligibility for PrEP is unclear because he has not been tested for HIV in 2 months and he may have been exposed during this period. This patient's HIV negative status must be confirmed prior to initiating PrEP, so that makes answer C incorrect. And I would like to add that because PrEP medications are also active against hepatitis B, the patient's HIV and hepatitis status must be confirmed. That makes answer D correct and answer B incorrect. I would also like to add that there is no indication for initiation of a complete antiretroviral therapy regimen, what we call HAT, in this patient as a bridge to PrEP. It doesn't make sense. Waste of resources. And I would also like to add that a complete HAT regimen would be indicated only if the patient's HIV status or test returns with positive results, and that makes answer A incorrect. Let's move to the next question, please. And it reads, Mr. AOC, a 25-year-old newly diagnosed male HIV positive patient, was initiated on HIV therapy, HAT to be specific, 30 days ago. Today, he presents to your comprehensive care clinic for HIV after being displaced from his home by inter-clan skirmishes, which have left thousands of natives dead. He has no significant past medical history, and he has no known drug or food allergies, and he presents 7-day-old lab results indicating a CD4 count of 88 cells per mm cubed, a viral load of 3,500 copies per ml. He takes bictegravir, tenofovir alafenamide, and emtricitabine daily. He, however, lost his OI prophylaxis medications. In addition to the HAT regimen above, which of the medications listed below would you recommend for Mr. AOC now? Would it be cotrimoxazole and azithromycin? Would it be cotrimoxazole and valganciclovir? Would it be fluconazole and cotrimoxazole? Or would it be cotrimoxazole, Septrin alone? I'll give you 10 seconds to choose the correct answer. I would recommend Septrin alone, cotrimoxazole alone. Now, because of his CD4 count of 88 cells per mm cubed, the patient is at a risk of PJP and may also be at a risk of toxoplasmosis. Now, a toxoplasmosis IgG level would confirm his risk. And I would like to add that prophylaxis against these infections consists of cotrimoxazole alone in patients without sulfur allergies. Remember, we are told he has no allergies, no known allergies. Now, because of his CD4 count, which is less than 88 cells per mm cubed, the patient could be at a risk of developing oropharyngeal candidiasis in addition to other OIs such as PJP and toxoplasmosis. Now, although prophylaxis using cotrimoxazole is indicated for PJP and toxoplasmosis, I would like to remind you that no primary prophylaxis is indicated for candidiasis, and that makes answer D correct and answer C incorrect. You don't need to do prophylaxis of the fungal infections. Now, treatment with fluconazole, I would just like to remind you, is indicated only if the patient develops Candida infection. We don't use it for prophylaxis. Now, fluconazole can also be used for the treatment of coccidioides and cryptococcal infections. But primary prophylaxis against these pathogens is not recommended if you read the guidelines. I'd just like to add that the risk of invasive cytomegalovirus, which is CMV infection, including CMV retinitis, increases in patients with CD4 cell counts below 50. Our patient here has not gotten there yet. However, primary prophylaxis with valganciclovir is not recommended. So that makes answer B wrong. Now, the best method for preventing CMV infection is reconstitution of the immune system with antiretroviral therapy. So that makes answer B incorrect. Now, the risk of invasive infections due to Mycobacterium avium complex, what we call MAC, increases in patients with CD4 counts below 50 cells per mm cubed. Our patient hasn't gotten there yet. And I would just like to add that when CD4 cells counts drop below this level, a macrolide antibiotic such as azithromycin or clarithromycin should be used as primary prophylaxis. I would just like to remind you that azithromycin is not yet warranted in this patient because his CD4 cell count is 88 cells per mm cubed. It hasn't fallen below 50, and that makes answer A incorrect. So there you have it, my highly esteemed viewers and listeners. That brings us to the end of this video. If this video benefited you in any way, I would like to humbly remind you to give it a thumbs up, to share it widely with your peers, and to like it, and to leave your comments at the bottom of the video. And if you haven't yet done so, I would like to humbly urge you to subscribe to my YouTube channel. I would like to promise you all that the very, very best is yet to come. Thank you very much for viewing this video and for listening to me. I sincerely appreciate your partnership, your continued support, and very kind collaboration. And I look forward to interacting with you in the next video. Thank you.